could still see it as well.
Okay. All right. I'll just keep going then. Sorry, I don't know why it's doing that today. So let's get started talking about the SARS-CoV-2 variants. So we have my objectives for today. One is to review the variants that we know are in briefly in the US and globally, and then really dig a little bit deeper into the 3 recent COVID-2 variant strains that have been of concern or have been in the news over the last few months. And lastly, I'll follow up with, what is the early information or the early data we have on these same variants and the monoclonal antibodies and vaccines and how they interact. So first, how do we define a variant? This is a strain where we have one or more mutations that change it from either the wild type original strain or the predominant circulating strain. And so currently, in the US, the predominant circulating strain is not the original wild type from before, but the variants that we're seeing are mutations that are different from our predominant strain here in the US. And there's actually been variants being reported since really the pandemic was first noticed, and they've been reported both in the US and across the world. And so it's not that these 3 are the first variants to come about, but they're the first 3 to really gain a lot of interest. And just for a brief review for those who aren't as familiar with viruses, variants happen with almost all RNA viruses in particular, because the RNA viruses lack that proofreading step when they're replicating to try and correct their mutations, unlike what we see with DNA viruses. And so examples, influenza as an RNA virus, there's a reason why the vaccine has to change each year and we have to get vaccinated every year. HIV, another RNA virus that can certainly cause mutations that can help escape some of the drug therapy that is used. And these mutations occur during replication, and sometimes they're of no importance at all. They don't impact the virus itself in terms of its fitness or its survival, or of the host who's going to be infected with it. But sometimes they will help to evade immune response. Sometimes they will help to increase their barriers to therapeutics or vaccines. And sometimes they're mutations that will help to increase their infectivity or transmissibility. So just on Sunday into Monday, the WHO reported, and this was in a press conference, so it's not that we have a publication yet, that they had identified that in December of 2019, when the increasing cases in Wuhan were first being reported, that there were already more than 12 variant strains circulating in Wuhan at that time. And so that shows you that this had been around for not just since December, but that variants have been happening since the beginning of this pandemic. And then just this week, as of February 14th, there was a study that was released in the US about 7 US variants that had really started showing it themselves in August of 2020, and continue to develop through November, and then as of January, February, becoming some of our more predominant strains here in the US. The difference with these is that they actually don't yet know what that impact is. They haven't yet been able to say whether these variants are showing increased fitness, increased transmissibility. I show this just to show how they're all involving a similar site on the spike protein, the 677 portion on the spike protein. And cleverly, they named them after birds here in the US. And so we've got robins, pelicans, yellowhammers, bluebirds. And the rise in these here in the US actually matched the rise of these in the world. And so we looked through last January 2020, February 2020, we did not have much of these variants showing. But as we got into late summer through the fall and winter, this Q677 mutation really dominated both in the world and the US. Although small numbers, though, number of sequences still less than 1,500. So that's the number of viruses that they've sequenced out that match this variant. And so that will certainly continue to increase as more sequences are being collected. So let's get to the bulk of this talk. So currently we have 3 new variants since fall of 2020 in the world that have been identified to have concerning features. And so there is the UK variant, which is the B117. There is the South African variant, which is the B1351. And then there is the Brazilian variant, which is P1 or P2. So this is a table that is available on the CDC website that was last updated on January 27th. But it kind of shows you these 3 different strain variants, where they were first detected, how many cases or when cases first came in the US. And so the UK variant was first identified in the US in December, whereas the South African and Brazilian were not until January. how much it's spreading across the world. So again, they haven't updated this since January 27th. And so I would argue that certainly more than 70 countries by now. And I would suspect that these numbers are also rising. And then it shows you some of the key mutations. And so I highlight this D614G mutation. So this is a mutation that's actually been seen in other variants, even as late as last summer, including in the predominant strain that's around the US. So that is not a new mutation, but it does show you the differences in how it's not just a single mutation in these variants that we're noticing.
Yes.
So if I look at this D614G, again, I told you that it was seen early in the US last summer, as well as in Europe. And it's actually been shown to actually help with transmissibility or infectivity. And what it does is it allows the virus to bind to the ACE2 receptor with more affinity. So our own immune system can't knock it off as quickly or as easily, so therefore it can infect more readily. Those other mutations that were listed are particularly of importance are the E484K, the N501, and the K417T. And all three of those are correlating to a receptor binding domain of that spike protein. So remember our virus, that SARS-CoV-2, the concerning point of it, or one of the concerning points of it, is that spike protein, which is what part of the virus binds to our cell receptor. So if we can't block that spike protein, then it allows itself to bind to our ACE2 receptor and then invade into our cells. And so it's been shown to increase transmissibility, but also our monoclonal antibodies, our vaccines are targeting that spike protein. So there is that concern that it's going to make those therapeutics less efficacious. And this is an example, just a diagram showing. Here's the SARS-CoV-1, and this is SARS-CoV-2. And this was a schematic showing a prior monoclonal antibody that was developed for SARS-CoV-1, also used in SARS-CoV-2, and how that antibody can bind to all of these spike proteins and therefore block its ability to bind to our cells. And so if the virus is able to alter that spike protein, we may not have those antibodies be able to bind. And that would include the antibodies that we develop from a natural infection. And so depending on what mutation occurs, it can have some impact. So back to this UK variant. So again, first came in the UK in September of 2020, late September, and then again in the US in December. And it does show that there's increased transmissibility available with this, and there's multiple factors, but one of the factors is that it has a deletion mutation. It's called the 6970 deletion mutation. And what they found with that mutation in this graph here is when they measured this units of reverse transcriptase activity. And so reverse transcriptase is the enzyme that helps the virus replicate. And so if the virus is replicating, then that enzyme is being used, and so the activity of the enzyme would be increased. And so this is the wild type, the original SARS-CoV-2 strain, showing what the activity of that reverse transcriptase was, compared to the deletion 6970, where it was twice as active or noticed. And so increase in replication, increase in transmissibility. They noted that the other mutation that's seen in the UK virus is the N501, which again is a part of that spike protein, and that it actually would decrease the activity of reverse transcriptase alone, but in combination, it still is able to overcome what the wild type replication rate was. And so this is why in the UK we saw a significant rise in the number of cases, is because some of these mutations allowed for increased transmissibility. And just from the UK this week, they actually gave out another report that was announced on February 11th that showed evidence that not only does it increase transmissibility, but it increased severity of disease and mortality. And this came out of NERVTAG, which is the new and emerging respiratory virus threats advisory group in the UK on SARS-CoV-2, and in particular on the variant B117, which is at UK. And their quote was, evidence from analysis of multiple different data sets that infection with the variant of concern, the UK variant, is associated with increased risk of hospitalization and death compared to infection with these non-variant strains. And I did not list all of the studies they included. They included a list of 12 different data sets. So these are just 4 of those 12. But the common theme among all of them was that the mortality risk, or the hazard ratio for mortality, the mean ratio of case fatality, the mortality hazard ratio, was all greater, so greater than 1, if you compare the UK variant as compared to the non-UK variant. And so that's where they came out with this conclusion. Now, There are caveats to this, right? So not every data set matched. They use different markers of measuring their mortality risk. Some of them did not match with a cohort of study. And so in these last two, they actually did include a matched cohort of those who had non-UK variant, but were still in the ICU or still at that same level of comorbidities. So more will come out of this once we see more data released, but this was the summary from the UK on February 11th. So increased transmissibility with the UK variant, increased severity and mortality. All right, let's move now down to the South African variant. So this is the B1351. So first detected in October of 2020 in South Africa, and then first detected in the US at the end of January. We have not yet seen evidence of increased severity of disease or increased mortality with the South African variant. But what we have noticed is that they have at least 3 different mutations that involve the spike protein, including this E484K mutation, which can impact the ability of antibodies to neutralize the virus. And that means antibodies that would come from someone who had already been infected with an original strain or another variant, or antibodies that are vaccine safe, or antibodies that we would get through a monoclonal antibody treatment. And then the P1, which is the Brazilian variant, it actually was first detected in Japan in travelers from Brazil. And so it was identified in January 2021, but found specimens from back in December that it was prevalent in Brazil at that time. And then it was first identified in the US at the end of January. And it actually has very similar, they share 4 to 5 different mutations as the South African strain, again, all involving that spike protein or that receptor binding domain of that spike protein. And so again, with the Brazilian strain, there is concern for the efficacy of both vaccines and monoclonal antibodies. And so what do we do about it? How's the response to these variants? So one, in the US, what's been going on is they're trying to increase the number of surveillance that we're doing of sequences, meaning not just are we reporting cases, but we're actually looking at those positive tests to identify what their strain is or what their variant is. And if we look back into December, we were doing maybe 100, 200 country across the CDC as to how many variants we had or sequences we had. Their goal is to get to 7,000 sequences per week is their goal, to then have a cumulative goal of over 40,000 sequences to look at and identify what the strains are. And you can see since January, or really into late January, they've been picking up on that and increasing the number of sequences that are being reported and published. And that's a collaboration between not just public health labs and CDC, but university labs and commercial labs. And so with that dashboard, they're able to then identify, okay, how many cases of these variants are we seeing? And as anything with public health, you know, the reporting is probably a few days behind. So this was updated February 16th. They update this every Sunday night, Tuesday night, and Thursday nights. And so there'll be a new one up tonight. But the UK variant, there's been over 1,200 cases reported in the US in 42 states. The South African has been only 19 cases so far. But again, that's going to go up, it's going to increase. And then it's across 10 states. And then the Brazilian, 3 cases, but only across 2 states. And limitation would be where we're getting sequences from, what states are participating more than others, for instance. But that UK one is the one that's of concern because, you know, there's discussion of how fast it's increasing. And so if we look at February 7th, there were 690 cases involving the UK variant. We come about 10 days later, there's 1,277. So that doubling of 10 days is true. That's what we're seeing with this UK variant. And that's the one that has that increased transmissibility. And so if we're identifying 1,200 cases, you have to imagine there's much more than that probably across the country that those sequences are being collected. If we look at it cases by state, again, this is through the CDC and updated as of February 17th. The green are states that have at least 1 to 100 cases. So it's a wide range, and they mentioned their reason for increasing that range of 1 to 100. They don't want to have too many colors in the map. So from 1 to 100 cases reported in those states, you'll see that West Virginia, at least as of February 17th, as reported to the CDC, we haven't had any of those variant cases yet. But again, that could change as of tonight. The biggest sites of these variants are California and then Florida. This is a similar map that actually uses data from the CDC, but they divided out by what type of variant is being seen. So all of the green states have just identified so far the UK variant. The yellow state is the UK and the Brazilian variant, and then the red are UK and South African. And so that's kind of a map of where we're seeing it. As you can see, the UK variant is across from the east to the west, north and south so far. So how does this impact our vaccines? And so this was looking at some of the Pfizer results. And so following vaccination, they looked at study participant sera. So these were participants of the phase 1 study where they had their serum still. And so they tested what was the ability of their antibodies that they got from the vaccine that's in their blood to neutralize these variant strains. And so I caution small numbers, an N of 8 to 20 total. And this was presented at the ACIP meeting on January 27th. So with the Pfizer, they actually found several studies that have demonstrated equivalent neutralizing titers against 19 different spike variants, including the N501 variant, which is seen both in the UK as well as in the South African and the Brazilian. When they looked at the UK variant alone, with all of the mutations that are in that UK variant, they saw on average a 1.3-fold reduction in that neutralizing titer, or a 3.9-fold median reduction. And then when they looked at the South African and Brazilian, again, they saw a modest reduction, but less than 3-fold for neutralizing those variant strains in those who had been vaccinated with Pfizer. And so this is where my slide for Pfizer had ended until last night, when there was a new correspondence published in the New England Journal of Medicine about the Pfizer vaccine, where they looked again at patients who had participated in the phase 1 trial after they had gotten their 2 vaccine schedule. And they looked at their serum and put into it an original USA variant that we had, followed by the D614G, which is a variant that came out really last summer where we had rising cases. As you can see, same level of neutralizing titer, so a 1 to 128 or 1 to 256 is where you want to be. Anything higher is better. They then compared it to the B135, which is the South African. And so this was looking at the receptor binding domain mutation, so not the entire variant, but with the receptor binding domain. And we did see a reduction, but the vast majority of those, now again, small numbers, the vast majority of those people still had a titer of 1 to 128 or higher, suggesting there was still going to be protection. And then they looked at the B1351 spike variant in that South African strain. And again, we did see reduction against the spike protein or that spike mutation. But again, the vast majority, 2/3 or more, still had a titer of 1 to 128. Now, these are all in the lab, right? So this is taking blood that they had stored from a participant in the trial and putting these variant viruses in it to see how much to neutralize. So clinically, we're still going to have to wait and see. But it does show that there seems to still be enough activity for the most part to offer protection. All right, so this is what we just went over with the Pfizer. What about the Moderna? Similar vaccine structure, right? It's an mRNA vaccine. So they did find that there was a modest reduction of less than 3-fold, again, against both the South African and the Brazilian variants, which would make sense. They have the similar mutations and the vaccines are very similar in their structure. There was another study that was actually done that did not show an impact on the UK variant, but a 6-fold reduction with the South African variant. And so this is what we knew as of January 27th. But again, just yesterday in the New England Journal of Medicine, there was a release of a study from, I think it was down in Texas, and a collaboration looking at the Moderna vaccine and these variant strains. And so this is looking at non-human primate serum after non-human primates had been, and even macaques, had been vaccinated with Moderna, and phase 1 human serum of participants in the phase 1 Moderna trial. And this is where they were comparing the different variants up until this fall. And so looking at that D614G, how are they able to neutralize or reduce that virus? And so across the board did well with all of those mutations. We bring in the non-human primates, looking at taking some pseudovirus where they use 2 separate viruses, but had them carry the same mutation that we're seeing with the SARS-CoV-2 variant in both the UK, which are the top 2 graphs, and the South African. And what they showed with the UK, as you can see, compared to the non-UK variants, or the one that's most predominant right now in the US, that it still maintained pretty well its neutralizing ability. When we look down here at the South African, you do see that there is a drop in the South African variant. And this is with the two different doses. So blue was a smaller dose of the mRNA vaccine, and then the red was the bigger dose. But there is a drop in the ability for it to neutralize with the South African variant, but not below a line of cutoff where you would say they don't have some level of immunity or some level of protection. And then they looked again at the phase 1 human serum that they had in the lab. And the same thing that you see with the UK, very little difference in that ability to neutralize that virus. Whereas with the South African, there was a drop, but the drop is not to below 1 or not to below even 2. And so again, it's hopeful news that we're still going to be able to have some benefit with these vaccines. What about the Johnson & Johnson, which is, with the FDA right now, we're waiting for its approval. This is that single dose vaccine that we use an adenovirus vector that carries the gene for the spike protein of SARS-CoV-2 that will develop the antibody to. So it had an 85% efficacy reported from their phase 3 trial against severe disease. So this is against, severe disease meaning those who would end up hospitalized or so forth. When they looked against mild to moderate disease, that efficacy was lower. Really, the goal of the vaccine, right, is we want to prevent severe disease, but if we can prevent any disease, that'd be great. But they had a 72% efficacy in mild to moderate disease in US participants, lower in Latin America, 66%, and then 57% efficacy in the South African participants, where 95% of them had that South African variant strain. So that would say that the Johnson & Johnson has an efficacy of 57% against the South African variant, which isn't, the 90-some% that we've seen with some of the earlier trials, but still good. And we think about the flu vaccine every year. If we can get to 57%, we're pretty happy with that. What about the Oxford AstraZeneca vaccine? So that's one that about 2 weeks ago, I believe it was, they actually had to halt their trial in South Africa because before November, it showed 75% efficacy in their trial in enrollees in South Africa who were getting that vaccination. Since November, when that South African variant strain became dominant in that country, they actually saw no difference among the vaccinated versus the placebo in their infection rates. All of those who got infected did have a mild to moderate case. They didn't see severe disease, but still to have no difference against placebo really made them have to halt that trial and re-look to where it can be used or where it would be beneficial. And then the last vaccine to talk about would be the Novavax vaccine, so it had a 95% effective against the original variant, down to 85% against the UK. This is still quite good for the UK, and then 60% effective against the South African. And that was what was reported in the British Medical Journal just this year. And so that's another vaccine out there that does still show activity against these variant strains. So we still have these vaccines as in our tool belt. What about monoclonal antibodies? So we've been using these monoclonal antibodies really in our outpatient settings to try and prevent hospitalization, severe disease. And so this is looking at the Regeneron, which is that cocktail. It has 2 different portions, as well as the Lilly product, or the bamlanivimab. And this was actually published in January 2021, but they did this back in November, in anticipation that we're going to see ongoing variants. And what they were looking at was, if we look at the red here, the darker the red is where an area on that receptor, that spike protein binding site, an area where the darker the red, the more escape mutations are present. And if you have mutations at that site, you're going to make that monoclonal antibody ineffective, okay? And so if we look at these 3 across this graph here, we see that the Regeneron 10933, there was 13 different escape site points where if that virus had a mutation there, it would make it less effective. Compared to the 10987, which only had 10 sites that they saw that actually had an impact on being able to escape that monoclonal antibody. And then the bamlanivimab we saw had actually 20 different sites that they noticed where there was an ability to escape that monoclonal antibody's effect. And so this was seen, again, back in November, that there were certainly particular regions on the spike protein of the COVID-19 that if you altered it, you could impact the monoclonal antibody. So then how does it do with these virus variants that we have? So this is, again, lab-based data where they actually did this in January of 2021. And they looked at using pseudovirus strains that had those genetic changes of the variants. And they compared bamlanivimab, which is the one that we've been using the most here up in Morgantown, against both the UK variant and the South African variant. And they found with the UK variant, they were actually still able to neutralize it effectively. compared to the South African variant, where Novavax completely lost its ability to effectively neutralize in a lab setting, right? So again, clinical practice we'll have to see, but in a lab setting, it lacked its ability to neutralize. Compared to Regeneron, which again is not an individual monoclonal antibody, it's a cocktail of two separate monoclonal antibodies. And they found that the Casirivimab lost its ability against South African variant, whereas the Imdivimab, the other portion of that cocktail, still retained its neutralizing activity. I'm going to show you that here with a quick little graph here. So blue is the Bemnivimab, or the Lilly product that we've been using the most. And so this is the UK variant. This is the D614G, which is a variant that's been predominant in the US since last summer. And this is the South African. And this is showing you the inhibition contribution it can do. And so for the UK, it maintained just as well as it did with the current variant we have. So they still stayed quite effective in neutralizing. Completely dropped off with the South African variant. If you look at the Regeneron combined product here, which is the red, so that's both pieces of it, it actually maintains itself pretty well against all variants when it's combined. When they look closer at the individual components, I showed this graph, there's a lot going on, but one, just notice how many monoclonal antibodies have actually been developed or are out there for use. We think about only two for right now that are being used in the US or used frequently in the US, but there's a lot out there. And what you can see is that the black line is the wild type, the pink lines are the UK variant, and the South African is the yellow or the gold. And each graph here is a separate monoclonal antibody being tested. And so if I look at the Bemnivimab, or the Lilly product, again, the same thing that we just saw in the prior graph, the percent neutralization, the ability to neutralize, maintained for the UK, still up to 80 up to 100% neutralization, compared to the South African, where it was reduced to about 20% neutralization. And so that shows you that that Bemnivimab will not be one that would be as beneficial in the South African variant, at least in a lab setting. Clinically, you would propose the same thing, but we'll have to see how that plays out. This is the Regeneron 10933. And so this is that one component of that cocktail that did lose its ability to neutralize, okay? As you can see with the South African here. Not completely lost it, but not as beneficial as it was. Compared to the other component of the Regeneron cocktail, where it still maintained its ability to neutralize that South African variant and the UK variant. So this is just a graph showing that these monoclonal antibodies, some of them will be impacted by the variants. Where we can have a cocktail or a mix of one or two, we may be able to overcome some of those mutations. So I really want to stop there so we have time for some questions, but just for a summary. So the variant strains, they're expected in viruses, particularly in a pandemic situation where you have millions of people infected, that millions of bodies where this virus is replicating and allowing itself to then have these imperfections or these mutations that develop. The UK variant is the one that's continuing to spread the most across the US. And again, probably they're predicting to be the dominant strain that we have by end of March. There is a concern given that, will there be another surge in cases? And so that's going to really be decided upon how we interact in our states, in our communities. Are we still following the recommended guidance? There's going to be a concern if it does surge with the UK variant. There was a study of increased mortality, increased severity of disease. But again, the vaccine was shown to still be beneficial with that. And then the current South African and Brazilian variants are the ones where there has been a drop in vaccine effectiveness or monoclonal antibody effectiveness, but not a drop to zero, right? And so the two published studies that came out yesterday is giving us some more hope. So how do we respond? Again, we need to continue wearing our masks, we need to continue to social distance, continue to wash hands, in an effort to reduce the number of people infected totally across the US, which would then allow those variant strains to not be able to spread, right? Because they can't spread unless people are continuing to be infected. And then increase our vaccination efforts, which we've done a great job here in our state. And so kudos to Dr. Costello and all of those involved with that. But if we can get our level of immunity up, again, it gives another benefit against those variant strains to keep them at bay. And then, the drug companies and the vaccine companies, they are actively already working on adjustments to both vaccines and monoclonal antibodies to counter these mutations. And so we may see down the road that we're going to need either a booster vaccine or potentially, if a new variant comes out that is not going to be as effective against these vaccines, that we'll see some new changes to that. But there is work being done against these variants, but these are an expected thing to see in a pandemic, and these will not be the last variants that we hear about. So I'm going to stop there and open up for questions, I think.
Thank you so much, Dr. Reese. We truly appreciate your time and putting this together and making sure that it's so current and up to date. So thank you very much. I guess we can jump right into the Q&A. We got some questions in the chat, and I encourage you all to continue submitting the questions as we go through them. And Dr. Costello, I see Dr. Sarwari is on as well, and I think if Dr. Moffat's still on as well, we open it up for you all to help with any Q&A as well. So the first question we got was asking if there are any studies showing sudden onset of hypertension or exacerbation of hypertension following COVID infection or the variants.
I have not seen any reports of new onset hypertension or a sudden onset hypertension following a COVID infection. Certainly, I would probably need to know more about, what was the severity of disease. We know with COVID there are some situations where they will have a cardiac involvement, and so was that a continued hypertension? Was it an isolated episode? What else was going on? But I haven't seen it reported as a outcome from COVID infection.
Thank you very much. The other question we got in was asking, so they said recently Los Alamos National Lab reported a new recombinant of the B117 UK and B1429 California, where the new hybrid recombinant possesses the high transmission rate from B117 and antibody resistant from B1429. So they were just asking, what is your opinion on the emergence of such VOC?
Right. So I think that's going to be the issue we're going to face, right? Is that these variants don't stop with their first mutation or their second mutation. And if there's a lot of them circulating, right, they can start to take you can start to see one virus incorporate mutations that were with another virus, particularly when we have so many number of cases, so many people infected and so much mixing happening. So though right now the vaccines are showing to be able to neutralize the UK variant, which is the one that's going to be the most prevalent here in the US, if that gets other mutations with it or combines with some of these other variants that are out there, we may lose some of that. And so this is why there's going to be that increase in sequencing that the country is going to start doing, where we get more and more sequences submitted to actually map those out and map out those changes. And then test, right? So if that combination that Los Alamos is reporting, if that starts to become a dominant one in an area, well, does the vaccine work for that? Again, you test that stored blood you have from these vaccine candidates and see if it's working.
Thank you very much. And if anyone else would like to chime in as well at any time, just feel free to unmute or chat in. And I just want to mention a comment we also got in saying that it was a super interesting presentation and thanking you. So just had to put that in there as well. So the next question we got was asking about your thoughts on a reasonable number of random sequencing from positive cases to actively monitor the emergence of VOCs.
Can you repeat that? Sorry, I was reading one of them in the chat, sorry.
Yeah, no worries. So someone was just asking about your thoughts on a reasonable number of random sequencing from positive cases to actively monitor the emergence of VOCs.
So I don't know if I can give a reasonable number. I think it would certainly depend on, are you speaking of a reasonable number from one area? Because if I just look at a reasonable number from West Virginia, I may be missing what's happening around the states around us, right? Because certainly people are starting to travel again. So I don't know that I have a reasonable number to say. I think the more the better, right? So if we can, the more sequences we can do, the more we can track where these variants are and where they're going. I think that's what, the problem with from the CDC is, we don't have if I only do 1,000 and 800 of them come from California, I'm not going to get a representative of what's happening in the country. So increasing that number as much as possible to get us such better data that you can.
Absolutely, thank you so much. And Dr. Fournier also chatted in saying that they're seeing more positive COVID antigen tests with negative PCRs. Could it be anything to do with a variant? And she was saying that they weren't seeing this much discorrelation earlier on.
Right, so this has actually been a question that I've seen raised on some other calls I've been a part of, and it should not be the case. So that that PCR test that we're doing is detecting those RNA particles or pieces of the virus, and these mutations should not alter the ability to detect that RNA. And so I have not seen that there is false negatives happening among these variants, at least not reported yet.
Thank you. And Carrie also chatted in sort of saying that she believes there are reports of a variant that are more severe in children. So I don't know if maybe you could comment on that as well.
I might defer to my pediatric colleagues because I have not seen that. But again, I don't do pediatrics, so I don't know if Dr. Costello or Dr. Moffat have heard anything about this, or Dr. Gupta, who might be on.
Yeah, I haven't. I think it goes back to the whole point of still trying to get better detection of this. I know that there's some work in our state to try to work collaboratively so that we could do some of this sequencing, you know, within West Virginia. Our pandemic leadership has frequently spoke to how we're trying to be, you know, self-sufficient and certainly are looking at ways to do that better here. So I don't have any case. The biggest thing I think that we've been seeing in peds more recently, including just today I saw, and we certainly have seen this here, and Dr. Gupta recently presented on this, is for whatever reason we are seeing an uptick in MIS-C cases. And so it's unclear at this time if that has anything to do with the new variants, or maybe we're just, you know, looking out for it more, or what have you. But there has, and we've seen that in West Virginia, but also have seen that reported nationally. So as Dr. Reese did so well articulated, I think it's time will tell, and we're still, even though we're a year in, we're still learning very much about this virus and all that goes along with it. But I don't know, I also see Dr. Khan from Charleston on, so we have a good group of ID specialists here, so I don't know if anybody else has comments.
I agree. This is Shapra. I agree with Dr. Costello. I have not seen any reports, but the preliminary, the numbers of our MIS-C have gone up. But is it because of the surge that we had, and we've always seen that 4-week or 4 to 6 week lag from our surge to our MIS-C cases? So I would say more to follow on this to see how the variants play out. And the variant that was initially reported from UK, it's supposed to be predominant by March. That's the model through CDC that's being predicted. So I'm hoping we don't see a surge with our vaccination and our public health measures, but that would be when we shall see how things pan out.
Thank you, Dr. Costello and Dr. Gupta. Anyone else who wanted to comment on that as well?
I'll just make a quick comment here. So to me, this is very reminiscent of a previous pandemic in the last 40, 50 years, the HIV pandemic, when we started being able to use one of the therapeutics, Atripla, very, very widely. We became worried about the K103N mutation and the transmissibility of HIV with that mutation. And it is a signature mutation that gives you resistance to that drug. So much so that genotyping prior to starting therapeutics became a standard. So when you look at this pandemic with the lens of what we've learned from other previous pandemics, it is not uncommon that over time variants will select out. Some will have an impact, a lot don't. And then essentially the sequencing piece is going to be our main tool to make sure whether the monoclonal antibodies or the vaccines continue to remain effective. So it's interesting. The HIV pandemic played out over 20, 30, 40 years. We are seeing fast forward the same thing play out in a few months' time.
Thank you so much, Dr. Sarwari. All right, The next question we got in was asking if you have data on convalescent plasma for patients who have had COVID and also received the vaccine to see how they perform against the VOCs.
Yeah, I didn't share the one on the convalescent plasma because partly we're not using that as much in our therapeutics. So the same thing as what has been noticed is in those who had one of the original strains or the initial variants, with the Brazilian, the convalescent plasma actually was not as beneficial, and even more so in those South African, because the antibodies that you developed for that initial strain and against those spike proteins, for instance, won't match the spike protein in those variants, so they've made those alterations. As a whole, convalescent plasma has really kind of fallen off, I think, as a treatment modality for COVID because of the limitation in trying to get it in as early as possible, that by the time you diagnose someone who's in the hospital with COVID, oftentimes they already have an antibody response that's equal to the amount they may be getting in someone's convalescent plasma. But yeah, so that's going to be one. So if we are seeing patients who are able to be infected with these variant strains who had a prior infection, that means that a convalescent plasma from a prior infection would not be beneficial in that variant strain.
Thank you, Dr. Reese. The other two questions we got in were a little more of general COVID questions, so I'll still go ahead and ask those, but again, I'll open it up to anyone who can respond to them as well. So the next question we got was asking, are there any data on asymptomatic infection and potential to transmit infection after a second dose of vaccine?
So that's the biggest question we have, right? So we know that from the trials with the vaccine, what they were looking at was symptomatic disease or severity of symptomatic disease. And that's where that percent of efficacious comes from. Now, it's interesting, in I think it was in the Moderna trial, they actually did, for a subset, started swabbing people when they came in for their second dose. That's before, it's not after the second dose, it's before the second dose, and found that there were less asymptomatic cases in that population, but it's small numbers. So I don't know that we have the data yet on does it help prevent asymptomatic disease, and we're probably not going to have that data until we have a larger proportion of our country vaccinated to see that. I don't know if Dr. Costello has heard anything else or seen anything else.
No, I was, Dr. Reese, there's few times that I have something else to add other than you, but I did see something from John Hopkins recently. They shared on like social media talking about, that at least from what we're initially seeing, we think that's going to be the case, but I agree wholeheartedly with Dr. Reese that I think we just need to see larger numbers to truly make that a determination if it's going to really impact that to decrease disease transmission as well as to decrease asymptomatic spread. But I do want to just give a big shout out to Dr. Reese. Dr. Reese has helped the state in many regards. People may or may not know that the state has a medical advisory group compiled of many different health professionals, and Dr. Reese has been incredibly generous with her time. And when people ask in West Virginia, how have we been so successful, it's really people like Dr. Reese and there's other people on this ECHO as well. But I think that's what's really put us ahead, to have forums like this in Project ECHO, but also the expertise of talented docs like Dr. Reese. So I just wanted to say thank you to her. A lot of the materials that you see out there from the state come through review by numerous people on this chat, but certainly Dr. Reese. So I just wanted to say thank you for this excellent presentation, but also for all that you're doing to help our state. Along with everybody else on the call, we're all got to keep going, keep climbing as we continue to try to turn the tide on this pandemic.
Absolutely. Thank you, Dr. Costello. And I couldn't agree more. Absolutely. We truly appreciate you, Dr. Reese. And Dr. Leonard, I noticed you had chatted in a question. I didn't know if you wanted to maybe unmute and ask it. You could probably articulate it better than I can.
Okay, this is something I just heard and wanted to run it by the group. It makes absolutely no sense to me. And again, it's a rumor. I'm trying to get a hold of the letter from the transplant team that advised she was a biliary atresia baby had partial liver transplant, probably about 4 or 6 months. Whenever they do it, maybe 9 months. And she's about 4 now. And the family has reported to my wife and friends that their transplant team advised them not to get one of the mRNA vaccines. There's nothing that makes any sense to me, right?
Yeah.
I don't want to be disparaging toward that transplant team, obviously, but so
right.
we don't shed anything. It's not a live virus, so this doesn't fit current thinking, correct?
Exactly, and I would agree. I would do what you're trying to do, which would be to verify with that transplant team or that doctor, because you're right. The mRNA vaccine, you're not getting any live virus. There's no risk of you developing a COVID infection or even shedding any virus, because it's an mRNA that's going to give you a exposure to that protein, that spike protein gene, that you make an antibody to it. There's no virus particle there to really cause any problems. I think, the guidance would be for someone who has an immunocompromised person in their house. Yes, you can get vaccinated, but you should still take your precautions and wearing masks and so forth, because again, we don't know that's going to protect you from an asymptomatic infection that you can still spread to your loved one, but not from the vaccine itself.
Thank you, Dr. Reese. Dr. Costello?
I was just going to say I agree with all that, and I think that what I'm seeing in some cases, and I think that's where we all as varying health professionals in the state, like I think you're doing a good job of trying to find that out, because what at least I'm seeing and hearing more, like there are people like one-off make this recommendation that might not be based upon what the guidance is nationally. And I think that it is tough, because a lot of times we are found to say, well, it wasn't studied particularly in that population, but this is what we think, like Dr. Reese just articulated. So I think driving back to what we do know is going to be important, because as this progresses on, as we anticipated it would, there is a lot of misinformation. There's a lot of myths out there. And so it's important in forums like this to bring things like that up, but also to do our part to try to debunk that, because really we're seeing great progress thus far, but as Dr. Reese has said, we really have to get to higher numbers to really reach that, what we think and hope will be, community immunity or herd immunity. So I think we'll probably continue to hear things like this, and it would be helpful to find some more out. But thanks for presenting that, because I had not heard that either. And I think, it could be worrisome, because if they would contract COVID, I think the potential of that would be far more devastating than potential, any side effects or anything that may be seen with, vaccination. And that's what I think I've found myself pivoting more. I've had a lot of friends, colleagues ask about, if they're pregnant or what have you. And I think, we in West Virginia have seen maternal deaths. COVID is not benign to pregnant women. And so I think, we talk about, obviously we want more studies, but we have to remember the severity of getting COVID and what that could mean, and particularly in an immunocompromised child, that could lead to severe complications or even death. So I think being mindful of that in our discussions with patients when they're deciding if they want to choose to be vaccinated is going to be important now and moving forward.
Absolutely. Thank you for that. And we got a chat in kind of going off of that from Samantha asking, could that have something to do with a normal immune response?
I'm not sure if the question's about a normal immune response in the family member, because there's not a risk from your immune response to the vaccine of passing that to the person who has the transplant. If the question is, should the transplant patient receive the vaccine, that's where we don't have the data. That's where we don't know what their response will be to the vaccine. Like, will they actually mount an immune response that would be protective or not? And so that's the group that definitely was not studied. But I'm not sure if I'm understanding the question correctly from Samantha.
Samantha, feel free to unmute as well if you'd like to ask in more depth. Absolutely. You're more than welcome to, or chatting in as well, and I can ask it again. And so we have about like 5-ish minutes left, but I think we'll have time for one more question before the poll. Let's see, Dr. Leonard, I noticed you chatted in saying update on the studies down to 12 years. Did you want to unmute and sort of expand on that as well?
I just wonder if I haven't seen any updates or any preliminary data on the newest studies where they're looking down to 12 years of age.
Yeah, the last I heard, Dr. Leonard, that they were having a hard time recruiting participants for that. And so I think it's taking a little bit longer to get the data that we all want. I believe Dr. Fauci was quoted, thinking that probably in summertime, we might be able to see more, adolescents, because that's really the next group that we'll be seeing, and then moving into the fall, if we're able to get to younger age. I think a lot of that depends upon supply. Dr. Reese talked about the Johnson product. I think that, within 2 weeks, if unless something would drastically change, I think we're looking at that product being authorized. So the last I'd heard, it was just that they were having a hard time recruiting enough number of participants. But the goal was still probably like by summertime, hopefully there would be enough data that we would be able to determine if it's effective and safe in that population. So,
but it should be, right? I mean,
that's what they think. That's why Pfizer, actually, the Pfizer product was authorized for 16 years and older, because Pfizer did, although it was not a huge number, they did include, they were able to recruit 16-year-olds, and that's why that product is authorized for 16-year-olds, whereas Moderna is 18-year-olds. And so, that's what we think. But I think as a pediatrician, and at least I know the American Academy of Pediatrics, until there are those clinical trials, it's important to, make sure that we get that data. I will give a plug for, there's a AAP, it's called Pediatrics on Call, and they have a podcast. And this most recent episode includes Dr. James Campbell, who is out of Maryland, who designed a lot of the clinical trial protocols for adolescents and children. I got to co-present on a town hall with him back in December, but it has some good information about like the clinical trial process, particularly when it comes to children and what we'll be looking for and things like that. But I think that we're going to anticipate that, but I think we need to continue to have science drive our decision making and see exactly what the data shows. And really, in all of these vaccine trials, whether it's Pfizer, Moderna, or now Johnson & Johnson, they were studied at different times. So I do think it's going to be interesting in the child studies, the clinical trials, because now we have these variants. It's just a different time, where now that we are seeing more people be vaccinated, so we're seeing decreased cases in our state and across the country. So it will be interesting to continue to follow this as the trials continue on.
Thank you so much, Dr. Costello. And Samantha, thanks for chatting that in. I'm happy your question was answered. So we are at the end of our session hour. I wanted to leave a few minutes for the poll. So Dr. Reese, I cannot thank you enough. I know you did this same topic last week at the nursing home meeting, and doing it again today, and everything on top of everything else you do, it's truly incredible. And we really appreciate your time today. So thank you very much.
Okay, happy to be here. And then I was going to put a plug in. Every Saturday, the CDC and the IDSA does a clinician call. That's a webinar that's live with expert speakers. This Saturday is actually on variants. So there might even be more data coming out. And it's free, and everyone can attend if they would like. It's just the IDSA CDC clinician call.
That's incredible. Thank you so much for sharing that. If there is more information on that you would like me to distribute to everyone, feel free to email that to me. I'll make sure it's in the recap email along with your PowerPoint and everything. So thank you very much. Also, big shout out to Dr. Costello, as always, for helping to answer questions and being our biggest supporter. We truly appreciate you. Thank you, Dr. Gupta, Dr. Sarwari, also for helping to answer with questions. And thank you all, of course, as always, for asking the questions. It wouldn't be possible without you guys. So we truly appreciate it. Our next session will be on March 4th from 12:15 to 1:15, so keep an eye out for that reminder. I'll make sure to include the direct Zoom link with password in that reminder as well, so you guys will have that for next time. I will go ahead and launch the poll now, and anytime you guys finish the poll, just feel free to log off, and we'll see you guys next time. Thank you so much.